Hi, my name's Dr. Warren Wiechmann. I am the Associate Dean of Clinical Science Education and Educational Technology here at the School of Medicine, and super excited to be part of UCI's 2021 homecoming. I'm an anteater 5 times over. I got my BS in Biological Sciences in 2000. Graduated the School of Medicine in 2006. I also finished my MBA in 2006 here at UCI, and then residency 2009 and fellowship here in 2010. So definitely an anteater through and through, and excited to be here. Even more excited today to be joined by Doctors Peter Chang and Daniel Chow, both of whom are assistant professors in radiological sciences here at UCI Health. And even more impressive is they're both co-directors for the Center for Artificial Intelligence in Diagnostic Medicine, as well as co-directors for Precision Health through Artificial Intelligence here at UCI. We're going to have a great discussion today about what is artificial intelligence. And so I just wanted to welcome both Doctors Peter Chang and Dr. Daniel Chow. Thank you, guys.
Thanks for having us.
All right. So we've heard a lot about AI before, and it's been in the news a lot more frequently. But what exactly is AI? There's other terms I've heard out there, such as machine learning or deep learning. What do all these things mean?
You know, that's a great question, Warren. And I think the terms oftentimes get misused and or used in various contexts. So I'll quickly try to disambiguate what you might have heard. Artificial intelligence is really the umbrella term that really encompasses any type of computer system that tries to replicate intelligent behavior. And, you know, if you use that broad of a definition, really anything dating back to, Alan Turing and the first computers really qualifies. Machine learning is a relatively recent term, about 20 or 30 years old, whereby we realized that a human in combination with data, lots of historic data, can be used together to produce intelligent type predictions. So a human sort of helps frame the question, and then a machine is able to mine historic data to help answer and draw some interesting conclusions. Deep learning, which is the newest term, sort of the newest technique on the block, is about 10 years old. And it is really the first sort of paradigm shift whereby big data alone, without any human help, supervision or guidance, is enough for an AI system to learn intelligent behavior. So another example I like to oftentimes throw out is chess. Traditional chess engines from 20, 30, 40 years ago would use a human to come up with reasonable strategies and ways to win the game. And then a computer, supercomputers, then used to process a ton of different moves. With deep learning, for the first time, we don't have to inject our own strategies or thoughts or sort of assumptions into the process. We really have a hands-off approach where the AI system is really able to come up with any strategy it wants on its own. And it's really the driving technology behind a lot of the recent innovations with self-driving cars and facial and voice recognition. A lot of the big breakthroughs in recent years have been primarily driven by this most recent trend in deep learning.
Very cool. So this all sounds really, really complex, but you mentioned a couple things that there is, AI and deep learning, machine learning that are actually in our sort of everyday lives. Can you expand on kind of what those items are?
Oh, absolutely. So I think one of the best examples, most tangible examples, is voice recognition. As recently as 15 years ago, voice recognition was a military-grade endeavor, right, with lots of funding to solve very simple problems of understanding everyday speech. And now, through our cell phones, through a smart home device, through Google or Alexa, we all have access to cutting-edge, state-of-the-art, deep learning-enabled voice recognition. It's ubiquitous around us today. And again, it's completely shocking to know that as recently as 10 or 20 years ago, that would not have been possible.
Very cool. Okay, that makes a whole bunch of sense. So then, since we're starting to see this now, Daniel, yeah.
I was just going to add one example. Deep learning is in our Zoom right now. The live caption that you see at Zoom, that's recording all of our speech and figuring out what we're speaking. That's deep learning. So, it's an easy example. It's what's transcribing this conversation.
That's awesome. It's hard to realize, you don't even realize that this sort of exists out there. It sounds very kind of future and sci-fi, but realizing that it actually is present in some of the things that we're using daily now is really cool to see sort of under the hood how that all works. So then that's kind of the everyday life. How is this being applied into medicine and healthcare?
So it's a fantastic question. I would say as of about 5 years ago, medicine has slowly started to catch on to the trend, and we're starting to see a little bit of this technology creep into our day-to-day workflow. Most of it is on the research side, where myself and Dan spend most of our time, but there are a handful of applications that are being used to guide patient care today. A great example right now is work myself and Dan are involved in sort of a COVID analytics tool, right? New disease process. Not a lot of information is known. As clinicians, you may not have a good reference standpoint to really help manage and make decisions about these COVID patients. And so together we built a tool to essentially analyze a profile of a patient that comes in the emergency room and predict the likelihood of this patient needing some sort of escalated care at any point during their inpatient admission. So that's one very tangible, relevant case, that's timely to the pandemic. And there are a handful of others. It's basically along this sort of theme of assistance or guidance to help physicians synthesize all this information that we're obtaining for each patient.
And then it's also, I think, we're going to start seeing more of this in terms of, I think we're starting to see different incentives start to evolve in this area. So one example that happened in November of this year was CMS, Centers for Medicare and Medicaid, now actually have a new technology add-on payment ruling for acute stroke patients. So for the triage of these patients, if they use a tool with AI for large vessel occlusion, they will reimburse an additional $1,040 per patient. And so what we're starting to see is more and more of these, and I think there used to be a question of if we build it, they will come. But now we're starting to see the government kind of starting to incentivize if it's actually adding value or improving outcomes. So it's very exciting.
Right. In our world, that what Dan said is absolutely correct. Incentives need to be aligned. And I think just to highlight what Dan said in maybe more explicit terms, this is the very first reimbursement code for deep learning AI in medicine. It happened in November of last year. And, just kind of on a dime, all of a sudden the interest, in this field, which is already high to begin with, just spiked. And really many radiology departments now in the country are all in the mix because of this new advancement.
Wow. I didn't realize that the CMS was starting to do that. That's a huge move forward, especially, and it's also sort of indicative of the times, right? Looking at the nature of how technology is working in medicine, that it's not just a sort of a fringe thing anymore, right? It's a key part of how we are practicing medicine or researching or trying to look at risk moving forward. Mm-hmm. So I'm really intrigued by some of the work that you're doing. You mentioned this COVID tool. Again, even though we're almost a year plus into COVID here in the U.S., there's still a lot of unknowns and other variables with COVID. Can you tell me a little bit more about how that tool works, just to give us a little timely example here?
I'll start off, Peter. Yeah. So I think, when this was around February, we were starting to observe February of last year, we're looking at both China and Italy, and we were starting to see increasing numbers. And we knew that this was going to hit the States. And so what we were also observing was that this was a novel virus where some patients were doing exceptionally poorly and some patients were doing well. And so one of the things that we wanted to do was, could we just make a machine learning tool to use analytics to identify those who are high risk, those who are most susceptible to doing poorly, which we defined as going to the ICU. And one of the challenges was, from a clinical standpoint, there was so much information coming out. We had surveyed the literature, and we found that there were 80 potential inputs that may or may not be relevant. The other thing that we observed was that things relevant for China or Italy might not be relevant for our population in the United States. The best example was in Wuhan, one of the papers that they had listed for risk factor was anorexia, whereas we know in the United States, our risk factor is obesity, or they had hepatitis as a significant risk factor. And for us, that's not as high as the prevalence as it is in East Asia. And so, our populations are different, and there was a need to be able to rapidly integrate a lot of data. So, our team worked with the hospital, and we had multiple collaborators. This wasn't just us. We had inputs from nursing, biological sciences, School of Medicine, ICS, nursing, public health, and we were mining a lot of the data of our COVID patients to identify in order to identify these COVID patients. And then I'll leave it to Peter to describe what he did next.
Well, so, my workflow is very, it's common to many projects, which is that folks like Dan and clinicians have a great idea and they have data and they just need help to analyze and build tools around what their experience is. And so, with all the hard work Dan and his team did, we were able to then take that data, feed it into multiple machine learning models, and build a user interface around the tool such that it was as accessible as possible, right? It's actually a public website. Anyone in the country can go and access that link and plug in a few lab values and sort of see the risk score calculated in real time. So anyways, it's something that we're very proud of. But I want to emphasize again, of course, this is all a significant collaborative effort, right? We provide just one piece of that puzzle, which is the analytics, but bringing it together into a useful tool and then getting adoption and all these other things, right? It's really a team effort here.
Yeah, and especially with the hospital, we had Dr. Alpesh Amin, we also had Bill Wilson, and they really looked at it, thought that it was useful and integrated into the clinical pathway, and we've had really good outcomes with that. So I think that's why really having that tight connection between on the research side, translation side, and actually deployment side was really, really neat. I mean, we went from approval to prototype to in full deployment like in less than 2 or 3 months.
Super cool. And, being an emergency physician, we've definitely used the tool down there. And you guys are right. It's as simple as, from our end, from the end user standpoint, simple as putting in a few numbers. But with this disease where there's so many unknown variables, age at times doesn't seem to make a difference, and other risk factors, it helps having some sort of tool to help guide that clinical gestalt or clinical feeling that you have, and it's been super helpful the times that we've used it down there, and especially with a relatively kind of novel disease process like this, any additional information and data points definitely help. So thank you both for your efforts in pushing that forward, as someone who's used it there in the front lines. Now I know also you've done a lot of work even before COVID. It wasn't just COVID where you sort of got your feet wet into this area. I'd love to hear about some of the other work that you've done, the clinical work or some of the other research work that your groups have done.
Absolutely. Well, so both Dan and I are imagers at heart, right? We're radiologists. So a lot of the focus, at least on day one, was on diagnostic imaging. A lot of the initial work was actually specifically in stroke imaging because that is our specialty in sort of our day-to-day life. And so certainly tools to help identify stroke patients early, and importantly, the stroke patients that may go on and require further therapy. I think that's one popular category. And if you extend that even on a larger scale, AI tools to help prioritize the work list, to help physicians attend to the sickest patients first. I think across the board, that's one of the most common themes that we're seeing, not only because it's useful, because it's actually also something that AI solves very well, right? One of the key advantages of AI right now is that it's fast. It can look through 100 patients and find the 3 or 4 that actually need your care and attention right now. So again, across the board, not even just in our lab, but across the country, that's one of the biggest themes that we've seen.
And then I think, one thing that I'm starting to follow more on is looking at what is the actual value added and operational impact. So, Warren, I'm following in your footsteps. I'm getting my MBA now here at UCI. And I think a lot of the research that we've done in the past and in the community has really focused on what is the technical efficacy, what is the diagnostic efficacy. But really, the questions that we need to be asking is, what is the diagnostic impact, therapeutic impact, and operational impact? And there's this question now. Let's say that this is to play devil advocate. Let's say that I'm able to diagnose faster, or let's say that I'm able to triage faster. does that actually mean that we're going to have better outcomes? Or let's say that I can improve access, to a point of care imaging. Just because I have now created more access, does that mean efficiency is going to improve? There is a phenomenon in traffic patterns called Brace's paradox, where when you open up more highways, you can actually sometimes increase traffic, or when you close a highway, sometimes you might see a decrease in traffic. And these are the kind of questions that you have to look at. And the other thing that I think that puts us in a unique perspective is that we are an academic site, and so we're not beholden to try to raise money. We're really beholden to what is the evidence for this. And one of the concerns that you have for this field is that you might have this, almost like a supplier-induced demand phenomenon, where you have everyone peddling their AI tool. You have a circumstance where the clinical benefit may or may not exist, however, it's readily available. And when you have those circumstances in healthcare, that leads to overutilization. And so while I fully believe that these tools in the long run are going to hopefully reduce healthcare costs while also improving quality, we do need to establish the studies and figure out what are the use cases. Maybe like, for example, a hemorrhage detection tool. UCI is a good example. There's a lot of tools right now for detecting hemorrhages, but do we need that on at all times of the day? Do we need that from 8 to 5 when I have 6 neuroradiologists? Or maybe the biggest use case is between midnight and 6 a.m. when there might be 1 or 2 radiologists working a night shift. How is this going to be used most effectively and efficiently? Does it make sense to use it for everyone? And then the final question is, what are going to be the social economic changes from this? Is this actually going to improve delivery of care to multiple groups? And also, the real fun question is, how does this change our practice and change our other ordering habits? So, for example, if I'm able to detect more strokes, am I going to, through a LVO tool from CTA, does that result in me ordering less MRIs? Does that result in other things? We don't really know yet. So I think these are important questions to ask.
I'll piggyback off of that and emphasize or maybe highlight. So what Dan talked about is essentially the key questions that relate to what happens when you actually use AI in a clinical setting. There's many AI programs across the country, especially in the past few years, they've become quite popular. But in my mind, one of the things that sets us apart is that variability to take a tool that we grow in our own lab and then flip a switch and start using it clinically. That's how you get to answer those questions that Dan brought up, which are, again, absolutely critical. These are the unanswered questions right now in this space.
Again, just utterly fascinating. So I think the two parts that are really sort of bringing home, it's not just this all sounds amazing, and we have this new technology at our fingertips, and we should figure out tools and how to use it. It's not just that part of how to use it, but I think the fact that the two of you are looking into the why and the larger implications, because we've seen missteps before with other technologies where a really fascinating technology didn't really have a home, and there was a lot of that square peg round hole sort of phenomenon where they just tried to make it fit, and it didn't really have a huge impact. So I think that the fact that the two of you are being extremely mindful about kind of where is its place and how does it change the system, and not just the individual behaviors, but the system behaviors, I think is a really, really key part of this.
I'm going to piggyback on that comment you just made, because I know Peter has a really good example for mammograms for fitting, what is it, the analogy used, fitting a square peg in a round hole?
Yeah, I mean, this is a little bit more technical, but yeah, the bottom line is if you don't have physicians necessarily part of the mix throughout the whole life cycle, not just when you're ready to use it, but actually conceiving an algorithm and designing an algorithm, then in fact you will be predisposed to just taking generic off-the-shelf algorithms, the tools that everyone else in the industry is using, and then just blindly applying it into our world. Exactly what Warren was kind of alluding to. Without a customization, right? Without sort of critically thinking about the problem, you might be prone to think that a mammogram, which is the example Dan was referencing, that a mammogram is the images are too large, so I'm just going to shrink them down so they fit right into these conventional algorithms. I can still see the breast, right? I can still see all the things I need. But again, to an expert neuroradiologist, you'll quickly see that, in fact, the high resolution is needed because the cancer is really just a few small specks of calcification that are impossible to see otherwise. And so again, if you're not careful and you you sort of blindly apply the standards of practice everywhere else into, even the algorithm development side of things, you might quickly find you're deviating from the right course.
Right. Well, Peter, that was an excellent segue to my next question. I know we didn't quite plan that out, but so it sounds like having this physician level of involvement, from that conception phase of these algorithms is key. So how did you and Dan get involved in this, and where does one start? I mean, there's two different questions, but how did the two of you get started in this space?
Yeah, it's good questions, and me and Dan have very different perspectives. So I'll give you the perspective of someone who, as a physician, also loves developing software code and data science. And Dan can give you the perspective of someone who has a more clinical, focus. I would say, my own personal experience came as a self-taught programmer. I actually never took any formal classes or training during my undergrad years, but it was an interest I had for a long time. And then when deep learning started taking off in radiology, about 5 to 7 years ago, I was in a good position to use kind of the skill set that I had developed. It became very valuable very quickly to have a physician that spoke the same language as my developers and my data scientists. I then ended up actually getting involved on the industry side. I consulted for a few companies, and then I created my own startup. And so a lot of my experience, again, on the technical software development side comes there. It comes from interacting with industry and actually building large engineering teams to make tools, several of which are now FDA cleared. So that all sort of segued up into about 2.5 years ago when, thinking that I might do that full time and step away from medicine completely, that sounded like, the most logical next step. And then, Daniel called me up and he was here at UCI already. And he said, hey, listen, I think you're doing some pretty cool stuff. Maybe we could try to spin it up here at UCI and build some new, interesting kind of initiatives together. And so, long story short, we were able to pitch and fund a great new research initiative here, which in my mind helps drive and accelerate a lot of the research that's going on elsewhere on campus. Anyway, so that's my journey. And I know we'll talk about education and other things later on, but I think that's, the ability to weave some technical training into that medical education process, I think is critical. It's a new, untapped and unmapped sort of field and landscape right now. But I think it's an absolute critical blend of skills that is rare, but proves to be very useful in this field.
And I have a very, very different background. So for a lot of my talks, I have a disclosure slide. It's a meme. It's from Dr. McCoy from Star Trek, where he goes, "Darn it, Jim, I'm a doctor, not an X. So, I'm a doctor, not a software developer." I think, my interest in this came out to the very first thing that you said, Warren, is what is the why? And I think it's very much, I've always been very interested in research pursuits, very interested in translation. And the reason why is, ultimately to improve health and well-being. And I think one of the things that we've all can agree with medicine is that as a wonderful field as it is, we have not been very disruptive, and we've been very, very, very slow to adopt new technologies. You think about stuff with talking about AI, we talked about earlier, we're already seeing AI in our Zoom chats, AI in our phone. It's already very, very ubiquitous. And I think, it's very, very relevant that, there is going to be a digital healthcare disruption. It's already happening. And the reason why is to really improve health and well-being. I think one of the reasons that really drew me to UCI was that we have a very, very tight-knit group of community, and there's a lot of barriers are eliminated. You think about what we did with COVID-19. Me and Alpesh, we have a phone call almost every night now. I'm able to talk to Dr. Fox on a regular basis for a different project. I talked to Dean of Public Health when we were looking at the socioeconomic impact. What other world where you have an assistant professor able to talk to the chair of medicine on a regular basis, or the Dean of Public Health, or people in charge of biological sciences, and all with the same goal of improving health and well-being and being able to deploy these tools. And so I thought that was a very, very, very unique opportunity. And at the same time, what Peter said, Peter and I, we did our residency together. We trained at fellowship at the same spot. And I was here and I knew what Peter was doing, and I'm like, this is really where the future is going to be. And at first I thought, Peter, I know you've heard it here that every hospital and every institute says that we're different. And I'm like, no, Peter, UCI is really different. They will honestly let us try to make a mark here and make an impact here. And because I knew that we could really deliver and improve on those things. And so I think that's really kind of rung true. But again, I think the most important thing for why we do this isn't just to make some cool piece of technology, but we're all physicians, and really how can we improve the health and well-being of our communities. And in our specific interest is how do we integrate technology and assess that to be able to do that.
Awesome. You're right. You both have two unique sort of ends of the spectrum, but we're all very glad that you both converged here at UCI to kind of team up and with your superpowers and make this all happen. So we're very excited about that. So it sounds like in hearing about this, right, you don't necessarily need a specialized degree or 10 years of computer science work of churning through code to make this work. I know you've done a little bit of work with our medical students as well. So how do you see learning this skill set, this sort of craft that the two of you are developing? How do you see that fitting into medical education and that sort of future of healthcare for that next generation of not just physicians, but even nurses and pharmacists? How do you see that fitting in?
It's a great question, and again, I think me and Dan will get it from two different angles here. So. I'll start quickly, and I want to go backwards to your point, Warren. You're correct. It's a deep learning is a field right now that is so new that it turns out that if you have a few years of experience, you're kind of considered cutting edge. You've mastered all the main skills that you need to be successful. And that's kind of, I think that's appealing in some ways. It makes the barrier to entry a lot lower, I think, than it would have been 10 or 20 years ago, where you needed a PhD and you needed a lot of, sort of extra training. So the accessibility and sort of the open source nature of a lot of this work, again, it helps make it such that we're able to engage high school students even. On the medical school level, I think there's many different ways to get involved. A handful of students have an extremely strong technical background and want to actually do everything from sort of getting knee deep into code. And for the handful of students that are like that, they have been very successful. Some have taken extended leaves in the year of research with our group specifically. Others I mentor through the medical student research program and others. So again, for a very small sliver of students, that's a very productive and useful way to get involved. For about 20 or 30 other medical students a year, there's ways to get involved with less technical skills. So you do need to know enough to be conversant and understand the key ideas and principles, right? But as long as you have a high enough level of understanding to then connect and work with the data science and software development team, I think that's a really nice happy medium. If you can read a paper that's published and explain to your data science team, yeah, this is what they did really well, but could we maybe add this additional cool thing, or maybe they did it without looking at 3D data. I think 3D data is going to be really useful for our problem. That sort of intermediate level of engagement, I think, is extremely valuable. But again, and Dan will probably talk about this more, we have to also acknowledge that the vast majority, right, over 90-95% of all doctors will never be able to sort of dive into the technical details very much. And there's still a ton of value, of course, there to be added. So there's a couple sort of workshops and things that I do, but I'll let Dan kind of maybe talk a little bit about his opinions on that side of things.
I 100% agree with Peter, and I think I want to highlight one key thing that you said is being able to be conversant and understanding specifically what are the limitations and what are the possibilities with this. Because right now there is so much hype and so much stuff that, how do I separate what is reality, what is going to be able to become real in the next year, 5 years, and 10 years. And I think, if you don't have that ability to be conversant, you're going to be taken for a ride. So, for the scientist, it might be like Peter said, working with a team to how do you design a project. If it's how do you annotate your data, how do you collect your data? The worst thing I've seen before is you'll have someone come in with data and you look at it and they didn't annotate it correctly, and they have to go back and re-annotate thousands of patients because they forgot to mark this one thing that's the correct way or something like that. Or how do you define endpoints? Because really one of the biggest strengths that we have as a medical profession is that we are the domain experts of our data. One of the projects I was working with Shruti Gohil looking at asymptomatic COVID patients. And what we found was like a traditional classification that EMR software did would have said that 20% of COVID patients are asymptomatic. But when you actually drill down into the data and use her definitions, the actual ID definitions for asymptomatic was, it dropped down closer to sub 5%. And those things kind of matter because it has policy implications and implications for how severe the disease is. And so you can have widely different outcomes based on how you define things, and we are the experts at that. Or for those who don't do research, it's still going to be important in your careers because you're going to get knocks on your door from a vendor wanting to partner or sell your software. And you have to be able to look at their data and say, this is real versus this is untested. A good example is a lot of the early FDA-approved softwares for, say, stroke detection or hemorrhage detection or whatnot, they would take data sets that were balanced where half the patients had the disease and half the patients didn't have a disease. The problem with that, though, is that real life isn't like that. Real life, maybe 5% of patients will have a disease. So when you take a software that's so used to seeing half the population disease, you're going to get a ton of false positives. So it's being able to look at that, ask those kind of questions, or ask, where was the data trained? And I saw another software company that all of the data came from one country outside the United States, and they want to try to use this in the population that might not have the same demographics. So being able to be conversant, understanding the limitations and the biases so that you can make a better decision, I think that's important. And I don't think that this is just unique to School of Medicine. So at Paul Mirage, they have, digital leadership, and they have a lot of this. We have a course now looking at analytics, how is this going to impact business, how it's already impacting business. There is even a small coding session. I had to do a small R session, Peter, you'd be proud. But I think that it's going to be ingrained with us that it's just kind of like learning another language and having another skill set. It's kind of like math. You have to have those basic skill sets.
Yeah, I mean the point that you two brought up, I think, is really important to restate. From the education side as well, that not everyone can take that deep dive and be the next Dr. Chow and Dr. Chang, but I think that key point of needing to be conversant, to have that familiarity with this content. It's AI is not going away. Deep learning, machine learning, that's not going away, and I think it's only going to be a larger part of both the clinical side moving forward. And so I think for physicians, it's going to be important, or anyone in healthcare, to know at least you said those limitations, those biases, those benefits, so you can make those smart decisions, or they can start thinking about it. And I think that puts a challenge on us in education to carve out the time in curricula so that we can let our students know about this, because it's going to be, in 5 years, 10 years when they're practicing independently, it'll likely be a big part of their practice, and they should be prepared. Yeah.
And to add on to that, really, we as healthcare professionals, we are one of the major stakeholders in this. It's not the tech company. We are the ones who are taking care of our patients, who understand the clinical challenge, who understand the clinical need. And, if I would rather it be us who are very, very involved, because if we're not involved, someone is just going to, come over and do something and say, hey, this is going to be the new standard. So it's very, very important to remain engaged and stay involved.
Right. That's a great point. Making sure that physicians are a key part of that discussion, so that it's not that non-clinical application that's, again, tried to be put in there. I think that sort of brings up a good set of questions then, right? For some of those AI tools that are out there now, you sort of mentioned that there are some out there, and maybe the two of you have a really good eye for knowing what works, but how does, the average physician who's practicing currently, and they hear about these AI tools, how do they vet these tools? Do they just, you said, take them out of the box and try and use them in their practice? What sort of things would you recommend before someone gets really excited and wants to start using it that you think they should consider before just hopping into, using a tool like that?
Well, I would say one of the first things, probably the most important, perhaps first thing, is to set the right expectations, right? So the problem with technology, especially in healthcare, is that it kind of goes from one extreme to the other. Sometimes you are super excited about a really new technology and it sort of overpromises that, you're gonna now improve your efficiency by 1,000%. And then it swings the other way where people become disillusioned with mammogram CAD, for example, tools used to help detect breast cancer, which have been around for 20 years, but are largely unused in clinical practice. So the key is to set expectations. And if I were to tell a practicing clinician today what I thought my assessment of the field is that AI is extremely good at doing things that are instinctive, reflexive type things that doctors do. So if I look at an image and it takes me 1 or 2 seconds to make a diagnosis because it's a very obvious bleed or it's a very obvious finding, then that is something I would expect AI to solve today in 2021. By contrast, to be completely honest, I have not seen compelling evidence, either in my own work or at others, where an AI is able to routinely outperform a human across many different scenarios, right? There might be some very small focused case where we get some slight boost in performance, but if you're gonna say something like, an AI is much better than humans at looking at chest x-rays, right? By and large, those are not really well-founded claims. They're again, sort of like very small focused data sets where you have a perfect selection of patients and you have inflated performance scores. So that's the reality. I think if you go in to a sort of evaluation type setting with that in mind, knowing that there are some limitations, but there are definitely some things we can solve today, then I think that's again the right place to start. And then to kind of continue what you said, Warren, I mean, just trying the tools, right? A lot of these companies now, they're going to offer you a chance to at least test things out, make sure it works for you clinically, and that's in some ways the best, right? Just some hands-on exposure and understanding to what's possible.
I would add on to that. I think I'll speak more to a generality. So there is at least in the radiology, where Peter sent me a really good article for, what are the technical check marks that you should go for, like, check mark for data, check mark for algorithm, for curation. And I can send you that paper and you can put that as a link. It's actually a really, really good read. And I would say more on a more holistic level, it boils down to what is the value added and does this serve a gap? Because if there wasn't a gap and this is going to do something, is this going to, just create more utilization that's not necessary? I think a lot of these companies, they've already satisfied the diagnostic efficacy and the technical efficacy of the tool. That's already been demonstrated. They wouldn't be able to get FDA clearance without that. But going to those questions now, what has your tool, is this actually going to improve diagnostic impact, therapeutic impact, patient outcome? And right now, almost no one has evidence that their deep learning tool is going to do that. Now, we think in principle that because I can diagnose faster or I can diagnose more accurately, I'm going to have a better outcome. However, I can play the devil's advocate. Let's say going to surgery 30 minutes earlier. Does that really make a giant difference? Or let's say that, how common is it, as a neuroradiologist, I see a CT and I call hemorrhage, and I call the nurse and like, hey, you have a hemorrhage, and like, yes, we're already in the OR, because they're there when the patient's getting scanned and they're there right away. So am I really going to, I might be able to improve my turnaround time metrics, but does that actually improve patient outcomes? So I think, what is it that you're trying to solve? What is the value added? What is the gap you're trying to meet? And I would push a lot of these companies that, I don't really care too much about your sensitivity or specificity. You wouldn't be able to get FDA clearance without that. So my question is, what is that? And if you don't have that, why don't you trial that to us? We'll measure it and then we'll see how it does. So, because, and the other thing is that the valuation for a lot of these softwares are totally bonkers. Like they've just done, it's just totally, you asked them, like, what is the valuation based on? They said, oh, we based on precedence of other softwares. And he asked them, oh, we based on historical precedence of CAD softwares. I'm like, okay, so, and a really easy example is that there's a company, I'm not gonna name them, but they have multiple applications for, say, hemorrhage, LVO, pneumothorax, etc. And each application is like $40,000 to $50,000 per year. If you buy the entire suite, you could hire 2 radiologists. Does that really make sense for your practice group or your setting? So But I think there's a lot of questions remain to be answered. So.
Well, that's good. I mean, a lot of discussions whenever we're talking about, AI in the education side. I think one of the fears that comes up a lot is, will AI, with all these things, AI, deep learning, machine learning, will that make physicians obsolete? And it sounds like right now the answer is no, which is great. So we can keep educating our students, so we're not pushing them into a specialty that's going to be replaced by AI. So it's good in that sense that it's not going to replace it. It sounds like there's still a pretty important role for physicians to have in developing these tools. And it sounds like, since we're still on that very early kind of upswing, really finding that sweet spot in healthcare for AI still gives us a lot of latitude in where things go and move forward. So that's great.
I mean, to build on that, Warren, I would say deep learning and AI are tools, right? They're tools in much in the way that you consider a stethoscope a tool, or some other device to help you make sense of data. At the end of the day, that's what deep learning excels at. It's able to look at more data than you probably can look at, and try to synthesize things in a more comprehensive way than humans may be able to. But at the end of the day, it's just presenting or synthesizing or reformulating information so that now, as a human, you can take a look at sort of the patient itself, the whole picture of what's going on, and make a good decision. In my mind, in the short term, in the next 25, 50 years, that's the type of applications that we're going to see. We're not going to see, complete replacement or obsolescence of human physicians.
And there's a quote, Peter's going to cringe because I don't even know who said the quote anymore. It's been used in so many societies. But I think the quote goes, AI is not going to replace a clinician, but it's going to replace a clinician who doesn't understand or use AI. Is that how the quote goes, Peter? I think it started at the Boston group, but I'm not even sure anymore.
Yeah, a lot of people like to claim credit for catchy quotes, but yeah. It's a true sentiment, though. It's a correct view.
Right. That's funny. So along those same lines, right? So we've talked about, so physicians don't have to be worried about AI taking over. What do you think from the patient side, right? Patients are starting to hear about AI. Do you think there's going to be an issue with trust, with AI? Will it be oversimplified in thinking that some algorithm or some formula is sort of dictating my care? Do you think there might be a problem with the trust? And if so, how do we as healthcare professionals using a great tool like this help build trust with our patients?
Well, that's a great question. One of the biggest issues right now, limitations, if you will, of modern deep learning is that as high performant as it is, it does not do a good job of explaining to you why a prediction was made, right? It's an active area of research, and there are certainly ways to get at that answer, but the default configuration makes it such that it's actually pretty challenging. And so I think that's a very, very critical thing as we try to look to build trust in these tools, not even just between patients, but as the doctor who has to then take that information and make a decision. We've seen, for example, that when you agree with the AI, you feel pretty good and you actually move faster. You tend to interpret an exam faster. But if you don't agree with the AI, well, then you actually take a second look now. Something that would have taken you 1 or 2 minutes now might take you 5 minutes because you don't want to miss whatever it is that the AI potentially saw. So that degree of interpretability, being able to unpack what's going on and to quickly agree or disagree with what's going on, and maybe to detect bias, right? These are all really important things that we're just, again, kind of scratching the surface of, and I think that'll be a critical piece to building that relationship. Not just between patients, but between physicians as well.
And I think this goes back to that supplier-induced demand and really the knowledge. If you look at more and more surveys, like in 2018, it was evenly split 50-50. And most recent last 2 years, consumers are now, or patients are now okay with AI being involved in either prescription or diagnosis of their care. So people are kind of on board for that. And I think it's not just health, but they're recognizing that we're already living with it. It's in my Amazon, it's in my self-driving car, it's in my Facebook. And so this is just a natural extension. But I think it's kind of like when you have a new pharmacy or drug, right? Do you want that company directly advertising to patients, or would you rather having the physician involved, knowing what the limitations are, knowing what it's indicated, and so they can explain to their patient, this is why I used it, or this is why I didn't use it. Maybe I'm not going to use this specific software for your care because it doesn't make sense, or maybe this is part of my care because it does make sense. And so having that knowledge so that you can better inform your patients is important.
Great. No, that's, I think, really great insight from the two of you. So I see that we're coming near the end of the time, and that went actually pretty quickly. So just sort of a last closing question for each of you. Thinking to the future. Peter, you mentioned 25 to 50 years, but it doesn't have to be that far away. But even just in the more near future, what is the thing that you're most excited about in this line of work, about what you're doing, or just AI in general? And we'll close with that.
It's a great question. I would say combining both what myself and Dan were sort of alluding to at multiple points through several questions, it's trying to build a tool that has clear and demonstrable benefit to the patient and to outcomes in a way that is that is unequivocal, right? It's obvious that AI is now here to stay and going to make a difference. And then to have that tool become widely adopted, we haven't done that yet, right? We're still in the early nascent stages, and the handful of tools that are being used are primarily being used to promote research and to examine future potential benefits. But if we're not there yet, and I think once we have just one application that meets that threshold and becomes widely accepted, I think it'll, again, completely shift the conversation.
I 100% agree, because right now I feel like there's a lot of noise. We know there's potential, and I don't think the LVO and type thing is. I think it's going to move the field forward. But I think what Peter said, once we find that one use case where the outcomes, the benefits is so clear, where you're improving value while decreasing efficiency, and like one of those paradigm shifting applications. And obviously, we don't know what it is yet, because otherwise, we'd be working on it. But once that happens, I guarantee it's going to be one of those disruptive things, like when people figure out this is the kind of application that we're going to be focusing on, you're going to see this giant disruption. It's the analogy that I kind of use is, imagine what your life was before the iPhone. It's like all of a sudden when this one piece of technology comes, and it's like there was a gap that you didn't even know there was a gap, and now it's like irreplaceable. I think that application is going to happen. I don't know if it's 5 years from now, 10 years from now, but it's definitely going to happen, within this generation. And once it does, you're going to see everyone get really, really hotly invested right away, because now they're going to funnel all the resources, and that's going to really propel. Peter, is that kind of an agreement?
I think so.
Awesome. Well, Dr. Chang and Dr. Chow, really grateful for your time today to talk about an area that the two of you are very clearly passionate about. And from our side, from the School of Medicine, and just personally, I had a lot of fun in doing this. Again, we are extremely lucky to have you as part of the UCI Anteater family, and we can't wait to see all the amazing things that the two of you accomplish. So thank you again for your time today.
Thank you.
Thanks, Warren.